Good morning everyone. Today I am presenting about the long-term outcomes of GDDs following failed initial combined trabeculotomy and trabeculectomies in refractory primary congenital glaucomas. So as you all know, in India our first choice of treatment for primary congenital glaucoma is combined trabeculotomy and trabeculectomy. Like any other glaucoma procedures, even CCT had a success failure due to the subconjunctival fibrosis or scarring, which can lead to bleb failures. So mitomycin C might have enhanced the outcomes of these things, but due to these complications of the usage of mitomycin C, we are not using mitomycin C in a much role. So GDD is the choice for refractory primary congenital glaucomas. So we already made a study comparing both non-walled and walled implants in pediatric glaucoma eyes in Indian eyes, where showing complete success is more in non-walled implants compared to walled implants, whereas qualified success is greater than 80% at 2 years. So to continuation to that study, we have evaluated the long-term outcomes of glaucoma drainage implants in primary congenital glaucoma eyes with prior failed primary combined trabeculotomy with trabeculectomies. So we have included all the primary congenital glaucoma eyes who have underwent GDDs, who have a failed CCT with greater follow-up of 5 years. So we have excluded the eyes which have less than 5 years follow-up and who had secondary developmental or acquired glaucomas and who had underwent primary GDDs. This is a retrospective study which included 60 eyes of 41 children between December 2009 and November 2019. We have defined success as intraocular pressure between 5 and 21 millimeters of mercury without AGMs as complete and with AGMs as qualified. Failure was defined as intraocular pressure greater than 21 millimeters of mercury with AGMs, where repeat glaucoma surgeries were required and complication needing implant removals and loss of light perceptions. So out of 60 eyes, 38 eyes underwent AGV, whereas 22 eyes underwent RT implants. So comparing the baseline demographics and clinical characteristics of the cohort between RD and AGV at different intervals of time. So before CTT, median usage of AGMs was greater in RD cohort, but after CTT and before implants, AGM usage is more in AGVs. But after undergoing glaucoma drainage devices, AGM need was much less in RD implants. So in both the groups, the median follow-up is 7.5 years. Coming to the complete success probability of walled and non-walled implants, the complete success of AGV implant is much less at 1 year, that is 18%, whereas RD implant it is 77%. Qualified success at 1 year is 92% at 1 year, and for RD implant it is 82%, whereas at 5 years it is 71% for AGV, whereas for RD it is 59%. So even after implantation, 12 eyes in both the groups required glaucoma resurgeries, whereas 29 eyes required non-glaucoma surgeries, especially like lens aspirations and penetrating keratoplasties. Coming to the complications, we have 8 eyes who had complications where 6 eyes required interventions. So choroidal detachment was seen in 3 eyes, where in 1 eye tube religation was done. So instead of doing tube religation, even hypotony persisted, leading to retinal detachment and phthisis. Conjunctival erosions and endophthalmitis was seen in 1 eye. So implant was removed and endophthalmitis was treated. So after 3 months, again TSCPC was done. In one of the eyes, there is a posterior displacement of the GDD. So implant removal was done. So after 4 months, again RD implant was done. Tube corneal touch was seen in 3 eyes. Higher IOP at presentations and longer duration from CTT to GDD were risk factors for failure of complete success, whereas older age at CTT was associated with failure of qualified success. So GDD demonstrated moderate to long-term efficacy in PCG post-failed CTT. Qualified success ranged between 59 to 71% in RD and AGV at 5 to 10 years. 10% eyes needed intervention to manage long-term complications. Higher IOP at presentations and older age at CCT were significant risk factors for failure.